Welcome everyone to the 2022 Matrix Summit and Poster Session. This is Poster Session A. I'm Ellen Cohn, and we have 40 minutes for the entire session. The poster presenters will introduce themselves loudly, please, and leave the remaining 2 minutes for questions. If we don't get to your question about a poster, please feel free to contact the presenter directly. All poster presenters can be contacted on the Summit Event Mobile application under Attendees tab or the Send a Message tab on the presenter's profile tab. As we also want to remind you to please vote on the poster that you like the best for the People's Choice Poster Award. So thanks so much for joining us, and we'll move on to our first speaker. That would be Ryan Baker and colleagues. And we'll get started. Ryan, could you please move ahead and audiovisual, can you please advance the slide?
My name is Ryan Baker. I'm the director or the administrator for the North Carolina Statewide Telepsychiatry Program. And I'm going to go over the maternal outreach through telehealth for rural services is our poster that we have here. So we were a funder right when COVID started on how we can help high-risk pregnant women from having to travel. We serve a 29-county area and only have 2 MFN specialists. So one of the things we want to do is how, with COVID coming on board, how can we leverage telehealth to provide services to these women? And it started with OBGYN office, with the Department of OBGYN, and they came to us, telepsychiatry, because we had been doing this since 2013. So we said, okay, let's see how many services we can bring to these ladies through telehealth. So there you see we have psychiatry, registered dietitian, behavioral health manager, i.e. licensed clinical social worker, a nurse navigator, certified diabetes educator, and MFN specialist that goes through there. Like I said, we cover 29 counties, and the biggest thing that we were taught, given the task to do is, especially our diverse population that we have, is how do we get the high-risk mothers that would, so what would happen is they would drive 2 hours for a 10-minute appointment. It's like, okay, how do we leverage that for telehealth? So we actually use the Zoom platform, Zoom Healthcare is all we use to set that up and get that. You run it just like a regular outpatient clinic would run. We have scheduled days and time to see these patients. And it flows. So we will see any patient, psychiatry-wise, we will see any patient regardless if they're pregnant or not pregnant. But the MFMs obviously will be seeing the high-risk patients. The thought process is the MFM is there to help assist the local obstetrician in providing care to those women and to get as much care in that community as possible before them having to transfer for delivery at the tertiary care facility in Green. That was the response to that. One kind of interesting thing that we found is our MFN specialists kind of poo-pooed psychiatry be involved in the beginning because they didn't think there was a lot of behavioral health needs for that. We knew it was going to be around 20%. They thought it might be 3 to 5%. Guess what we found? There's roughly 40% of the women we've treated so far needed behavioral health assistance. We've seen so far. It's a great coalition of a team effort which revolves around the patient and centers around them with all the different services. We meet bi-weekly with all the service lines that work together to go over what's working, what's not working, and come up with ideas that can make it more efficient and effective. I think my 3 minutes is up.
Thank you everyone for being here this afternoon. My name is Mia Bolofsky. I'm a current 3rd year at Sidney Kimmel Medical College, and I'm going to be presenting a qualitative study assessing clinical staff experience with deployment of devices to support patient engagement in telehealth. So during the COVID-19 pandemic, access to healthcare was severely limited, and it relied on a lot of virtual connectivity. And so this project aimed to close that digital divide and increase access to healthcare among Philadelphia communities. The FCC DOT project, or Digital Onboarding Task Force project, was formed to distribute devices such as blood pressure cuffs, pulse oximeters, and electronic scales that were synced up to iPads and transmitted data back to the patient EHR and back to providers. These devices were distributed to patients across the Jefferson Enterprise and given to patients with chronic conditions such as hypertension, heart disease, COPD, depression, and COVID-19, et cetera. And so our study population included any Jefferson Health clinical staff and clinicians who assisted in the deployment of these devices. And so we conducted semi-structured interview via interview guides over the telephone and transcribed these interviews. And we really focused on the barriers, facilitators, recommendations, and overall opinions of these technologies from the providers and clinical staff that helped to set them up. And so overall, we conducted 135 clinicians and staff and conducted 29 interviews, which were around 15 to 25 minutes long. And so the clinician provided us with this 1,000-foot view on the impact of remote monitoring on their patients and patient care in general. And then the clinical staff kind of gave us the specific steps of the setup process that they went through with each patient. The different things that we focused on in this study was the training and deployment logistics of the devices, feedback from the patients, overall recommendations from the providers, and the impact of the remote monitoring devices on patient care. And so in terms of results, it appeared that most clinicians and providers were only able to set up less than 5 devices. And this was because one of the most common barriers, which is lack of human capital. So we did not have enough providers helping to set these devices up, and there was not enough time per patient visit to kind of efficiently onboard these patients and get them up to increased levels of digital literacy to be able to use these devices effectively. Other barriers that we came across included difficulty with Wi-Fi connectivity, difficulty with syncing the data up from the devices to the cloud and eventually into the EHR. And then also data interpretation was an issue. And so other facilitators that we came across were in-person patient support versus virtual setup. The in-person hands-on setup seemed to be way better than the virtual support. We were able to provide low-cost internet access to some clinics, and we were able to also identify experts for referrals. So some clinics were equipped with IT support teams that greatly improved digital literacy with these patients, and were able to troubleshoot some of the issues that these patients might have had. I think the poster kind of switched over.
Could you send back, please, to Mia's poster? She has 55 seconds to go, and we'll give you some of her question time. Go ahead, Mia.
Yeah. And so overall recommendations from clinicians and staff were to ensure that patients have adequate support for the device setup, and then using the EHR to set reminders for both clinicians and patients. And what that means is that the patients would get reminders to continuously upload their data, and the clinicians would be aware of any data input they might have received on their end. And so overall, the participants and the patients were very appreciative of the remote monitoring devices. And I think that it's a unique opportunity to kind of improve patient confidence and health-seeking behaviors. But without an improved workflow and knowledge of best practices, we need to get those facts on board in order to make that dream a reality. So thank you so much, everyone. And if anyone has any questions, I'm happy to answer them.
You know, Mia, you were right on 5 minutes. It's amazing. Thank you. What we're going to do to make up the time here and to be sure that Ryan can present, I'm going to put all the questions at the end, okay, of the whole panel. So sure. I think, you guys have been flexible. I really appreciate it. We're going to move on to Caroline now. And Ryan, I will have you at the end, okay, so that we want to hear you also. Okay, go for it. Caroline?
Can you guys hear me? Oh, there I am. You can hear me. Okay,
very
great.
Well.
Alrighty. So hi, everyone. My name is Caroline Cotton. I'm a third-year medical student at the University of Virginia. And today I'm presenting my project on improving diabetic retinopathy screening images at remote sites with the implementation of autofocus and internal fixation. So diabetic retinopathy is a major microvascular complication in patients with diabetes. In fact, it is the leading cause of preventable blindness in the working age population in the United States. And the early stages of this disease often do not present with symptoms. And so it's incredibly important to screen for diabetic retinopathy in order to identify, treat, and prevent the progression of this disease. And so specifically in Virginia, the incidence of both diabetes and diabetic retinopathy are higher than the national average. And so the Department of Ophthalmology at UVA has worked with the telehealth department in establishing a diabetic retinopathy screening program in Virginia. So with this program, we send retina imaging cameras to primary care sites across the state, primarily focusing on medically underserved areas. And the primary care teams at these sites can then use the cameras to capture images of patients' retinas and send these images to UVA, where the ophthalmologists can then read the images and assess for any disease in the eye. However, we have experienced some significant barriers with this program. Our primary problem that we faced is poor quality of the images that we're receiving from these sites. Oftentimes, these images are too blurry, they're too dark, or they're missing important aspects of the exam that we need to see for a full review, including the optic disc, for example. And you can see an example of a poor image that isn't readable on the left there in the middle. You can see where the optic disc is in some of the vessels. However, it's much too blurry and too dark to get an adequate reading and see if there's any disease. And so this was a major problem that we needed to fix, because if we kept receiving the majority of images that weren't readable, then there's really no utility in this program. And so in an attempt to fix this issue last year, we installed an update to the cameras at 2 sites. And this update worked in twofold. Firstly, the internal fixation aspect. This provided a light for the patient to focus on during the exam in order to center the eye for imaging. And then secondly, the autofocus aspect. This was able to recognize specific landmarks of the eye. And then once it recognized these landmarks, it was able to stop the camera from moving, autofocus the image, and also auto capture the image, which significantly reduced the burden placed on the operator of the camera when imaging the patient's retina. And so my goal with this project, I wanted to see if installing this update actually did improve the images that we were receiving from the sites. And so I did a retrospective case review of 411 images from 40 different patients at 2 sites over the past year. And I specifically wanted to see if there's an increase in the rate of readable images comparing before the update and after the update. And you can see the results in the middle in that chart there. On the left side, prior to installing the update, only 37% of the images that we received were readable. And this was nowhere near the rate that we needed for the sustainability of this program. And then comparing this to after installing the upgrade, there was a huge increase. Over 92% of the images were now readable, and this was a much higher rate that we needed for the program. And you can see the improvements in the images themselves on the right image there. This is an image taken using the upgrade. And you can see this, it's much more detailed, it's much clearer, and this is an image that we can actually use to assess for any disease in the eye. So noting this significant improvement, we have already moved to install this upgrade at multiple other sites that use the same model program. And then in new sites that we're establishing, we're planning on using this same model camera with the upgrade already installed in hopes of having those higher percentage of readable images that we saw in this study here. So overall, this study supports continuing to grow the diabetic retinopathy screening program in Virginia. And with the higher rates of successful images taken and higher rates of readability, we can continue to build the program to reach a broader population in Virginia with better assurance of the quality of the images that we'll receive from both the old sites as well as the new sites that we wish to establish. And thank you, everyone, for listening. I'll take any questions if there are any.
That's wonderful. We'll hold your questions till the end. You guys are great presenters, and these are wonderful posters. Eric, we're moving on to you. I'm very interested in this. I have 2 brothers who are pharmacists, and I've taught in a school of pharmacy. So go for it, Eric.
Wonderful. Well, thanks so much for having me. My name is Eric Hopke. I'm the Department Chair of Pharmaceutical Sciences at Harrisburg University. I'm also kind of a part-time floater telepharmacist. So I'm also employed by RxLive, who we use this platform, this telepharmacy platform, to deliver pharmaceutical care to patients remotely, either through the telephone or through a Zoom call. And what we wanted to do was really look at hospitalizations and outcomes, hospitalization as an outcome. When we talk about telepharmacy, we really want to start to prove the value of access to a pharmacy professional, specifically a clinical pharmacist. So what we did to investigate the potential impacts that telepharmacy access has on hospitalizations, what we did was we basically did a retrospective two-arm study that looked at a big group of patients that are all outpatients that are participate or get their health care from a local clinic in Chester County, Pennsylvania. So we retrospectively looked at two groups from this big medical practice. One group had access to telepharmacy services. The other did not. And what we wanted to do was look at hospitalization rates through a 2-year period that happened to coincide with the COVID-19 pandemic. So we looked at 2019 and 2020. What we saw was that the opt-in group, this is the group that had access to telepharmacy services. We saw that this group had an elevated, or I should say, hospitalizations went up in 2020 compared to 2019. We postulate that that's due to the pandemic. And we see that same trend in the opt-out group. However, we see a much more dramatic increase in hospitalizations in 2020 compared to 2019 in the opt-out group, where we didn't see that same dramatic rise in hospitalizations in the group that had access to telepharmacy. So what does this really mean? Well, it means a few things. First of all, it means that this is a potential avenue for prospective study. We could not isolate potential clinical confounders here. We had roughly similar rates of diagnoses of type 2 diabetes, congestive heart failure, other cardiovascular disease, but we did not match that group to group. So there's always clinical confounders here. The other difference, or the other aspect that is a potential confounder, is participation in healthcare. Individuals that have access to telepharmacy services and participate are more, they tend to be more involved in their healthcare decision making, and that tends to correlate with better outcomes as well. So while interesting, this is more of an observational trial rather than a definitive clinical trial that's prospective in nature. So this opens up further study into the potential value of having a telepharmacy service on hand to reduce hospitalizations and the associated cost and tragedy that tends to come with hospitalization. So this research was published in the Journal of Telemedicine and eHealth. So we're super happy about that. And yeah, that's pretty much it. I'll stop a little early.
Thanks, Eric. That was wonderful. Very valuable efforts. I'll tell my brothers about it. Okay.
Awesome.
Could you advance the slide? We're going to move to Susan. And conflict of interest, I've published one of her papers in a journal. And there you go, Susan. Okay.
Well, and I thank you, Ellen, because one of the things I wanted to emphasize was here in Kentucky in 2019, in support of telehealth, our state legislation actually moved forward with imposed both telehealth coverage and payment parity requirements for Kentucky's Medicaid managed care organizations, and the commercial health plans in our Bluegrass state. Well, prior to onset of COVID-19, the planned work groups were actually established, and they mixed voluntary and appointed stakeholders so that we could steer the translation of this legislation into practice. I happen to be part of the school-based physical and behavioral health work group, and I was a co-chair. I'm an occupational therapist and a faculty at Eastern Kentucky University, and my co-chair is Eva Stone, who is a nurse practitioner, but also the health, the school-based health center manager for Jefferson County school system. So we were coming together looking from slightly different perspectives. One of the things we want to mention is that unlike medical providers, schools are legally required to ensure all students have access to education. And this included children. So we saw, due to COVID, a rollout of computers, video conferencing systems, and internet that actually supported teachers in being able to provide the non-traditional instruction. So in May, our work group started with about 62 members, and we had a core group of about 5 to 8 that actually worked on a virtual needs assessment survey. And in May, we launched it. It initially went to the Department of Education administrators, and then we also did convenience prompting, I like to say, as we sent the link out to all the professional associations in the state. So I'm going to give you a little bit more background for those of you that may not be as familiar with school-based services. According to IDEA, schools are required to provide special education services to children with disability. So when you look at the statistics in Kentucky, 15% of kindergarten to 12-year-old students qualify for special education during the 2020-2021 year. Special education providers include educators and licensed healthcare providers like nurses, psychologists, OTs, PT, and speech language pathologists. In the school system, PTs, OTs, and speech language pathologists and a few others are considered related services. So it's a little different animal as we move forward with looking at this. But schools are designed around this traditional brick and mortar service model. So in the pre-pandemic, use of telehealth had already been moved forward in our more rural areas where lack of service providers or travel was problematic. So like their medical counterparts, the pandemic forced all the school districts to adopt a virtual model of service to remain compliant with the IDEA. So just looking at our methods, what we ended up doing is, and again, back to what Ellen mentioned, my colleagues, Jade Rowan and Shirley O'Brien, and I were able to take a subgroup of this survey, and we were able to do a qualitative cross-sectional design where we captured school-based practitioners and administrators and primarily looked at occupational therapists. I'm going to share with you some of the more broader trends. So the 3 questions from all practitioners' lenses really wanted to look at the barriers and the supports. So along with the demographics, some specifics were selected, and the demographics really looked at provider identity. So you can kind of see on my poster, kind of looks at the distribution. And so our speech language pathologists are kind of who we'd expect to have the most voice. And for those of you that may not be familiar with school-based services, speech language pathologists are typically housed and associated directly with the school. And so of the related services, they're the most integrated with the school population. I will let you know that for the smaller analysis, we did get IRB approval, and we looked at the entire 167 respondents to our broader survey. And so 67 of the respondents did combine noted technology for students and providers, and they talked about that there were barriers. Unlike healthcare, reimbursements was not a great barrier in the school system. So is it time?
About 1 minute.
Oh, thank you for the warning. Okay, thank you. So the one thing I just wanted to do is just kind of share with you the barriers. So if you look at this slide, I think a lot of these are things that we saw consistent with what the literature says. Training, technology for students were top. Quality concerns, unsure how to initiate, security issues, collaboration needs, consent from the parents, and that's something that we often see in schools. They weren't sure whether it was needed. The technology for the providers. And again, in school-based services, there's often a lot of contract providers. Cost, workflow, attitudes towards telehealth, the reimbursement, even though that wasn't a factor, that was a response. And then access for providers. And then the last four were space, jurisdiction, and provider choice. So just kind of letting you know in conclusion,
Susan,
we actually, is it time? Okay. Yeah. Just to let you know, we are trying to launch a follow-up. Thank you so much.
Susan, thank you. And this is very valuable work. Your group is top of the pile in terms of school-based research. All right, so now we'll go to questions. We have, let's see, it's 4:31. We have about 5 minutes for questions, I'd say. So go for it. Ask anyone you want. It's a free-for-all, I heard, so I'm not going to be calling on you. Go ahead. You'll need to unmute.
I was wondering on the Mothers Project, it kind of reminds me, were you all looking at kind of like and I don't mean to be speaking out of turn. I have some colleagues that work in Australia where the midwife concept and the community health is, has been around for many decades. Was that some of the direction where because it looked like you were blending a lot of different providers in your Mothers program?
It actually, the directions came from the funder, which was United Healthcare Foundation. And they basically gave us free reins that here's X amount of dollars, figure out a way to bring as many health resources, care resources you can to these expecting mothers in rural communities. So we did do some research. We didn't see anything in Australia, but that is the concept, is what you're saying, is just bring as many resources as possible to the community. Now we've got to see if it's self-sustaining once our funding runs out.
Yeah. Thank you.
Okay, how about other questions? Yes? AV person has his hand up? No.
So my question is for Eric. For the pharmacy, what kind of intervention that was happening during the encounter of telepharmacists?
Great question. So the standard, what we'll call a consultation, is what the main deliverable there in that group, the opt-in group, received, and that that basically was medication therapy management. So we would have a clinical pharmacist review their medications, answer their questions, make direct recommendations to the providers if there's a drug interaction or if there was some sort of therapeutic duplication, et cetera. Monitor even renal function, looking at renal functions and renally adjusting, recommending that the doses be adjusted for the renal function. So typical clinical pharmacist stuff, just done in a remote way because we had access to the patient's past medical history and medical records. So that was the main intervention there.
Nice. Thank you so much. Thanks.
Thank you.
Yeah. So any more questions? We've got some more time.
I have another question for Caroline. So the images were taken by the patient themselves, or there was someone helping them taking these images at the primary care centers?
Yeah, so how the cameras work is the providers at the primary care site, they're trained on how to use these cameras, and then they take the images of the patient's retina.
Okay.
Mm-hmm.
Is it an app or is it a?
Yeah, so it's what it is, like it's this camera device, and then they hook up a phone to it. So that's how they're taking the images then, is like through an iPhone that's hooked up to the camera device. Yeah.
What kind of update happened to the camera that make that difference? Was it the type of camera or the software?
That was the software that I was describing with the internal fixation and the autofocus.
Okay.
So it was just like an internal update that we installed into the camera itself.
I appreciate your questions. You're labeled as AV Tech number 9, and clearly I don't think you're our AV Tech. Could you tell us your name? These great questions.
My name is Ahmed Alaban. I'm here in person. I'm not on the online.
Thank you very much. Great. Really appreciate it. Okay, let's see how much time we have. I think we're at the end of this. I'm going to summarize real quickly. And thank you for attending our poster presentation. I want to thank the AV staff who've been working really hard with us. I know this is the first time this has been done. It's not been easy. And we've been working all day actually to try to be sure things go well. And you came through at the last minute. So thank you. You can hear all these posters that are all recorded, and we hope that you'll not forget to vote, okay? And now you get a break before we start our panel B presentation. So I hope to see you there. And I promise we will be smoothed out by the time that starts, okay? So thanks again for all of your wonderful presentations. I wish I could vote more than once, okay? If I could, I'd vote for all of you. So y'all take care.